If there was no nucleus, probably we would have not needed the phaco machine. Rest of the steps can be done without the phaco machine. So we will be covering up. First and foremost is we need to understand the anatomy of the nucleus, which is concave backwards. So when we are trying to trench it and break it, this has to be kept in mind. That means the trench has to be deeper in the center. And all the procedures are to be performed into the central safe zone, where there is a maximum space in the eye. The cornea is convex forward, capsule is concave backward, so there is a maximum fluid and maximum safety is available here. Nothing should be performed into the periphery under the capsule, because the capsule is very close and the iris is very close, the space is less. If you try to suck it, slightest this thing you're closer to the iris will get sucked into it. So the parameters, what parameters we should use will depend upon how good is the anterior chamber depth. If myopic patient, you can keep a higher settings. In a hyperopic and a small chamber, you will have to keep a lower setting. Pupil and iris. The pupil is small, iris is floppy, you will have to have a lower setting. Zonules and lens and nucleus. So nucleus is hard. If you operate at a lower setting, you won't be able to operate, because you just keep on chatting, you will use a lot of energy. And of course, most important is what type of machine you have, what experience you have, what technique you are using. So when we are chopping, we need to have a good hold. So the hold depends upon the vacuum setting and area of the tip. That means if you want a stronger hold, you need to use the regular tip instead of a micro tip. But you don't want a stronger hole in a softer cataract, then you need to have a smaller, a micro tip to operate upon. And flow rate decides how fast the things will happen. So vacuum decides how strongly you are going to hold. Flow rate decides how fast the pieces will be sucked towards the tip. So when you want to remove the nucleus, there are techniques which is divide and conquer, chopping and stop and chop, and there are certain steps like trenching, splitting, chopping and phaco aspiration which you have to master. So this is the divide and conquer, simple technique. This was the chopping, where we used to bury and chop. The advantage of this technique is that phaco energy consumed is much less. And then the chopping came before the stop and chop, because sometimes when you are doing a chopping, you may not be able to separate the pieces well. So we thought, why not to make a trench initially like divide and conquer, split into two, and then go into the chopping mode. So the chopping terminology, most important is the vacuum seal. That means we bury the tip inside the nucleus body and then try to chop it so that it is lollipopped because of the vacuum. And then we have a central chop or vertical chop when we try to do it within the rectus margin. Then another is the peripheral chop or horizontal chop. If I put the chopper underneath the rectus margin, start splitting the nucleus from the periphery of the nucleus, and then there could be modified peripheral chop where the periphery of the nucleus is brought out of the rectus margin and then try to chop from the periphery. And then we normally use the term direct chop when we try to bury the tip directly into the nucleus without making much of the trenching, without doing much of the trenching and trying to chop it, which could be central or peripheral. So for vacuum seal, we nudge at the central part of the nucleus, not very superficial, give little bit of energy. Once it gets buried, then lift the foot pedal up, only the vacuum is on, and hold it over there at position 2. When we are doing trenching, Kelman tip is better because you can make far better trench, and the energy used should be such that there is no pushing of the nucleus and no bubble formation. Depth should be deep in the center. Width will be harder the cataract, wider is the trench. So now if you see this, so we are making this trench which is like your divide and conquer. You can see the cross over there. Once you are done this trenching, then you can split into two. And once these pieces are separated, you can just pull them into the center and finish off the surgery. So this is a peripheral chop So I usually make a small trench so that I can bury into the depth of the nucleus. You can see the chopper is underneath the rhexis margin, and we hold with the vacuum seal. Chopper initially horizontal, then we turn it vertical and then pull towards the tip. Once it comes closer to the tip, we separate sideways to get the split. Once again, we bury the tip, go horizontally, make it vertical, and then as you come to the tip, closer to the tip, just split it. So keep on chopping. Once you have created all the splits, you can just consume them. And the direct chop is also very important whenever the nucleus is unstable, because if you try to make a trench, it keeps on rotating. So after making a small depression, then you can just hold it with the high vacuum setting. I usually prefer to make a little bit of impression over there so that I can bury it deep, but many of them are expert enough not to make this trench and bury it directly. So once I have buried it, then just split it and chop it. So this is a vertical or central chop. We are not taking the chopper underneath the rhexis margin. We are doing everything within the rhexis margin. So again, our chopper is within the rhexis margin. We are burying it down and separating it. So keep on separating the fibers. Keep on separating the fibers. And once again, this is done. So that was the first video I saw was a peripheral chop, and this is a central chop. And when I'm removing the last fragment, I have taken my chopper out so that there is no leakage from the side port, and I have reduced my vacuum setting to 400 to avoid the PCR, because this is the time when there are more chances of PCR. So this is what I call as a modified peripheral chop. So once half of the segment has been removed, now it is possible to bring the another half of the nucleus in front, and I just bury this tip. Now instead of, because the vertical chop is little difficult and you are trying to bury it, so I pull the periphery out of the rhexis margin and then chop it. Starting from the periphery, the chopping is much more easier than trying to do the vertical chop. So a stop and chop, my preferred technique is a stop and chop, because in a very soft cataract it's difficult to do the direct chop, and in a very hard cataract also at times it is very difficult and easy to master, excellent control, and mostly predictable and reproducible even with the low-end machine. And most importantly, energy used for making trench causes no collateral damage. So this is just a stop and chop technique. So initially, if you will watch, we have removed the part of the epinucleus covering the anterior nuclear surface up to the rhexis margin. And once that is done, we will make a trench. So the first we remove the epinucleus, which is lying on front of the top of the anterior nuclear surface. Then we make a little wider trench. And the most important is the depth of the trench. Up to center, a little bit sub-incisional trench. If you are able to go up to the center, 1 millimeter on this side of the center, sub-incisional is fine. You can see still the central part is not trenched. Now you can see that central trench is there. If you are not able to achieve, then you can rotate and trench from the other side. If you are able to achieve, just crack it, and now this surgery becomes very simple.